Hi, welcome to You Didn't Get the Memo Show. I'm your host, Gloria Bailey Ray. As always, we have a fantastic show for you today, and my guest is so engaging, charismatic, as well as he is knowledgeable, and we're going to be talking with him about diabetes. But I want to first of all welcome all of you guys and thank you for tuning in to yet another great episode. Um, you didn't get the memo. For those of you who are new to the show, it's about providing you, the viewer, with relevant, fact based, mainstream information to help you be informed and to make informed decisions. The show is streaming live on Facebook, YouTube, as well as LinkedIn. Our show is interactive, so I want to remind all of you guys if you have questions or comments to place them in the comment section. We'll do our very best to respond if you have a question and acknowledge you with regards to your comments. Now, a general reminder for all of you is I'm going to ask you to do something for me. I have my own app, BTV app. And I am going to ask you to download that app because you can catch all of my shows streaming 24/7. That's right. 24/7, and all you have to do is to go to www.localbtv.com and download the BTV app. Look for the memo show. That's where you'll find it. And I appreciate you doing that. Also, I want to give a quick shout out to all of my viewers and sponsors, both nationally and internationally. Thank you so much for tuning in, you guys. My guest today is Dr. Harold Orr. And let me just tell you just a little bit about Dr. Orr. He is the Regional Medical Director for Anchor Health, providing compassionate, comprehensive hospice services. Dr. Orr is a graduate of Howard University with a BS in zoology and animal biology, and he received his doctorate of medicine from UCSF. Dr. Orr, I want to welcome you to the show. Thank you for being here.
Thank you, Gloria. It's good to see you, and I'm looking in great anticipation of exchanging ideas and information this evening.
Yeah, absolutely. So I always like to start with asking my guests, to tell us about their backstory. Tell us a little bit about your background, where you grew up, things like that, before we dive into this subject of diabetes.
Well, I don't want to take too much time because it could take a long time for me to tell you all those facets of my life. But in general, I think the important things, I grew up in Richmond, California, a little place called Parchester Village, which was the first suburban community built expressly for Black people in the country. There's a unique story behind that, which we don't have time to go into. Went to Richmond High, and then from Richmond went to Howard University undergraduate school and graduated from there. Then came back to California, went to UC San Francisco Medical School. After I finished there, I went back to New York and trained at Harlem Hospital, Columbia Universities, and then came back to California again, did 2 years in the Navy, moved up to Oakland with my lovely wife and my two children at that point, and we practiced in Oakland for about 16 years, then went to corrections medicine for another 15 years, and then decided to change and go to hospice medicine, which I've been doing for the past 5 or 6 years. That's kind of gives you an overview of my life.
Yeah, absolutely. Correction medicine. That's interesting. You and I go back quite a ways, and I'd actually forgotten about that. So let's jump in and just talk about what is diabetes. What is it and how is it diagnosed?
Diabetes is a disease that one's body does not handle sugar and glucose appropriately. Now, we all have sugar in our body. You have to have sugar. The cells and your muscles depend on sugar. Your brain, that is the one thing that the brain must have to function is sugar. But when you eat a meal, there's a response that happens with insulin in your cells. And when you eat that meal, the glucose or the sugar is consumed, and it brings your level down to a normal range. What happens with people with diabetes? There's an overshoot. the level never quite comes down to a normal range. Therefore, the sugar accumulates in the blood system and causes a lot of secondary problems. And the thing that that we always that we were always considering and concerned ourselves with is what excess blood sugar can cause to the body. And probably before I go to that, let me just say the different kinds of diabetes. There are different types of diabetes.
Okay.
One is
All
type
right.
1 diabetes, and that is the one that people are insulin dependent. Now, there are some people who are born without insulin, and they have to take insulin all their lives. There are some people who will be a type 2 diabetic. In other words, they're treated with pills for years, but then their pancreas burns out, and then they have to go to insulin for treatment. Then there are the
Mhm.
people who are pre-diabetic, who the numbers are abnormal, but they haven't quite developed a full-blown diabetic syndrome. And then
Mhm.
there are the gestational diabetes, those women who during pregnancy develop a diabetic-like syndrome. 40, 50, 60% of them go on to develop diabetes later in life. So
Mhm.
that's kind of what it is, the types of it, and to kind of give you a format from which we can discuss.
Okay. So when we talk about the tests for diagnosing diabetes, because a lot of times people don't know unless they get a particular blood test that they're even, the doctor says, "Oh, you're diabetic." I know I I had that happen to me, and I'm arguing, "No, I'm not." And they were looking at the hemoglobin A1C.
Right.
So can you talk, what
Yeah.
other blood tests?
There are a series of blood tests
Mhm.
that are available today. There used to be we would take a fasting blood sugar, meaning you hadn't eaten anything for at least 8 hours, and then generally in the morning we would take your blood sugar, and anything over 125 or higher or is suggestive of diabetes. Then there's another group of people. Let's say you take a blood sugar and just at any point during the day, and the doctor says, I want to get a random blood sugar, and it's over 200. Anything over 200 means you are diabetic. Then these new tests came out 15, 20 years ago, the hemoglobin A1C, which is an average. It actually gives you a 90-day average of what your blood sugar is. Anything above 6.5 or higher is consistent with diabetes. Anything from the 5.7 to 6.7 range is pre-diabetic. Anything less than 5.7 is considered normal. So you got fasting blood sugar, you got hemoglobin A1C. There's a classic test that's called the oral glycemic test, in which you're giving a sugar load, and they measure your blood sugar at different intervals to see whether or not your blood sugar can handle that. Your body can handle that sugar load, and if your numbers go exceedingly high, then it means you're diabetic. That's one of the tests they use lots in pregnant women.
Mhm.
But by far, the majority of people now use the hemoglobin A1C and the fasting blood sugar to make the diagnosis.
Yeah. Well, that brings up a question too, Dr. Orr, as it relates to the hemoglobin A1C.
Right,
I see commercials where you see people say, "I got my A1C down from 8 or 9 down
right,
to 7."
right,
And I know, depending on some parts of the country, and I'm speaking of family members, their doctors have told them that, "Oh, your hemoglobin A1C is fine. It's at 7." And I can think back to years back when I was working in the hospital and doctor's office. The goal was always to be 6 and under.
right. Well, here's the thing. It may be 6.5, 6.4, 6.4, 5.7 because you're treating it, because you're handling it. It
Hmm.
doesn't mean the diabetes is gone away. As
Right.
soon as you come off treatment, you come off that insulin, you come off those pills, you come off that diet, you come off that exercise, that hemoglobin A1C is going to jump back up again. It
Hmm.
just tells you that you are doing the right things in terms of managing the blood sugar. And different doctors in different regions may bicker and banter about this is a normal range or that's a normal range. Most times, under 6, you're okay, and over 6.5, you got issues. But it's a measure. The hemoglobin A1C is a measure of how well you are, or are you, or how well you are or not controlling your blood sugar.
Oh, okay. All right. So when we talk about um, diabetes, what are some of the health problems that having diabetes can cause?
That's really the thing that's so important, and that is, what does it do? Diabetes can affect any system in the body, any blood vessel in the body. That's why you see diabetics who go blind, because it affects those blood vessels in the eyes, and it causes them to rupture, and it causes bleeding in the retinal area. That's why you'll see them, and it'll affect the blood vessels of the heart. They have an increased incidence of coronary artery disease, meaning they're more susceptible to having heart attacks. They have diseases of blood vessels of the kidneys, and that's why so many of them go into renal failure and have to go on dialysis. They have problems with the blood vessels in their feet and their hands. So many of them you'll see have an amputated foot, transmit amputations, or amputations of one of the limbs below the knee, sometimes even above the knee, because the prolonged elevation of the blood sugar is injurious to the blood vessels of the body. And so it is all of those things. You have an increased propensity for stroke because of the blood vessels in the brain. So all of
Mhm.
those things are the things that we try to prevent by controlling the blood sugar.
Wow. To think about the organs that are affected by diabetes, and that in itself is, wow, that should be a wake up call, I would say, for a lot of
Yeah.
people.
I mean, it's increased risk of Alzheimer's with diabetics, depression, hearing problems, skin
Mhm.
infections. All these things can happen in diabetics. But if you are able to control those blood sugars over a
Mhm.
long span of time, you are less likely to suffer from these negative consequences.
Oh my goodness. Oh my goodness. Okay. Dr. Orr, we're going to take a quick break. And when we come back, we're going to delve more into how diabetes is treated.
Okay.
And you guys that are watching, if you have questions, hey, put them in the comment section. And for some of you, I just want to remind you that go to the links on Facebook, YouTube, or LinkedIn to watch the show live. But don't go anywhere. We'll be right back.
It takes less than 1 minute to find out if you may have prediabetes. You can do it here. But you probably won't. You're busy. Kids, work, show coming back in 48 seconds. So let's do this now. Hold up one finger if you're a man, women, 0. 3 more fingers if you're over 60, 2 over 50, 1 over 40. If you're not sure, keep in mind you're sitting on a couch right now, so 1 more finger if you're not very active. 1 finger if yes, 0 if no. 1 yes, 0 no. Next, find the body type that looks most like you and hold up that many fingers while I look around awkwardly. And that's it. If you're holding up 5 fingers or more, you probably have prediabetes. Sorry to be so blunt, but hey, you're busy. Just go to the site.
My Shiro doesn't always wear a cape, but she always has time for a hug, a smile, for going the extra mile. My Shiro stretches every dollar, puts in long hours, puts others first. But now it's your time, Mom. When you're ready to retire, we want you to be able to enjoy it. It's time to start saving now. A free 3-minute online chat can give you the personalized tips you need to start boosting your retirement savings today. Visit aceyourretirement.org/Shiro.
Hi, if you're just tuning in, you are watching the You Didn't Get the Memo show with me, your host, Gloria Bailey Ray, and my awesome guest, Reverend Dr. Harold Orr. And we're talking about something that should be near and dear, and I know it has affected practically every household or every person within a household. They know somebody who knows somebody, if it's not right there in their immediate family, and that's diabetes. Before we went to break, I said to to Dr. Orr, I wanted to talk about, how is diabetes treated? And Dr. Orr, as you're talking, I know that you talked about the different types of diabetes and you ran through that, but let's talk about, break it down, how diabetes is treated. Is it any different from gestational diabetes as opposed to type 1 or type 2? So, can you give us some insight to that?
Yeah, I think the common therapy that runs through all of them is diet, what you eat, and then the kind of foods that you're eating. You have to eat healthy foods. You have to limit all these cakes and cookies and all this stuff, and find more time to put fruits and vegetables and lean protein and whole grains in your diet. What you eat is critical in terms of controlling your diabetes. And the thing I actually always tell patients is that in diabetes, you, the patient, play a greater role in what's going to happen than I do. I can make recommendations all day long, but you have to follow the recommendations and do the things that will enhance your body's ability to control the diabetes. So eating healthy, eating high fiber diets, and low fats and low carbs, cut down on saturated fats and refined sugars. This is all diet. Exercise moves sugars into your cells so they can metabolize. I mean, 30 minutes a day or 10 minutes 3 times a day. It's not talking about 5 hours a day exercise, but consistent, moderate exercise will help to bring your blood sugar down. And then losing that excess weight. I know it's an eternal battle. I go through it every day myself. But losing that excess weight that we carry around goes a long way to helping you control your diabetes. So that's the first thing. So you'd go with diet. Now, some people, when they present, the blood sugar is so high, he said, look, I can't wait to just wait for your diet. I've got to start you on some meds. And there are a variety of meds that we use. The meds will do one or two things. They'll make your body either more sensitive to the insulin, so the insulin that is produced in your body will have a greater effect in bringing your blood sugar down. It may block your body's, some pills may block your body's ability to pick up blood sugar. So if you eat something, you're less likely to get into your bloodstream. And then there are others that help to release insulin when your blood sugar rises. It has an impact on the pancreas that stimulates an increased insulin reduction that you need when you have a meal. And then there's a final category. There are those drugs that metformin that stop the production of sugar that comes from that's made in glycogen that's made in the liver. So all of these different pills work different ways, and what works for you in your family may not work for your mother, may not work for your sister, your brother, your husband, but it works for you. And then the last thing we have is the insulin, and the insulins are just basically the variations are how quickly do they act, how long do they, and for what span of time can you expect them to act. And so they are the ones that they're the catch-all for if nothing else is working. You figure out which insulin works and when do you take the insulin. Do you take it just before you're eating? Do you take it after you eat? Do you take it at night? Do you take it in the morning? Do you take it in mid-afternoon? Trying to figure out, do you use a long-acting insulin or a short-acting insulin? Now, those are the things that you coordinate with your doctor. And you just won't necessarily be certain of what works until you start them on a particular pattern of treatment and then monitor the blood sugar. 3 months, monitor hemoglobin A1C to see where you are and see what the most effective thing. So we have treatment, yes. Do we have cures? Not yet. Then there is the more advanced stuff that people who are getting pancreatic implants, where they're actually taking pancreatic cells from one person and implanting in another person. If that works, then that would be certainly an effective treatment and possibly even a cure. And then one of the latter things are the pumps. You'll see people have these pumps that they wear that are putting out insulin all day long in response to glucose loads or sugar loads that you're eating. So all of these things make up the pharmacopoeia, or make up the pharmaceutical approach to handling this complex and difficult clinical syndrome, because you want to avoid the blindness, you want to avoid the heart attacks, you want to avoid the strokes, you want to avoid the kidney disease, you want to avoid the vascular problems and having to require amputations, et cetera, et cetera. And again, it's one of those disorders where you, the patient, play a greater role in what you're doing than the doctor. I make recommendations, but you got to follow them.
Right, right. Well, though, Dr. Orr, one of the challenges I think it is you're saying that the patient, basically, you're telling them to take control of this, but a lot of patients are hesitant to talk to their physicians about what's going on to really get a real deep understanding. And a perfect example of that is sometimes I know that I can go to a doctor and they'll say certain things, and I understand what they're speaking of from a medical perspective. But what about the patients who really and truly don't understand when you say saturated fats? They don't know what saturated fats is. And so sometimes doctors have to come, I don't like the word dummy down, but they've got to bring down what they're saying to the patient in order for the patients to even understand what they're talking about.
That's a valid point. And I think that I always think about it as a sliding scale, but the doctor's up here and the patient's down here, and it really should be more like this, even, where we're talking eye to eye. So I think that's a very good point, and that when I would tell people this, I used to always tell my patients this: if I say something to you that you don't get, and then you leave the office and you don't understand it, write it down, call me, come back next time, ask me that question, and let me explain it to you. Or when you're going into the doctor's office, write questions down that you have. And if you have a doctor who doesn't want to answer your questions, you need to get another doctor. If the doctor seems to be bothered that you're bothering him or her with what he plays off as silly questions, you need to get another doctor, because that conversation that you have with the patient is critical to the patient understanding what's going on with them and what they need to do to get better. So that's a very, very valid point. And that some doctors, we frequently use terms, we're used to using them because it's a part of our lexicon. But the patients have never heard those words. And we have to stop and break it down so that they do understand. Because the more they understand, the more likely they are to take a proactive role in dealing with their disease processes.
Right, right. I love it when I hear, someone say, my doctor told me that I need more fiber in my diet, and they're trying to figure out what did they mean by more fiber, right?
Right. Yeah.
So,
Yeah.
I mean, some of those things that you're talking about is just being aware of what it is that they need in order to really follow a good diet protocol. And sometimes I think we have to stop calling it a diet as opposed to just call it food management or something around that order, because it's amazing the number of people that I talk to who really don't understand what is happening as it relates to diabetes. And I'm amazed, younger and younger. I don't know if you're seeing that, but it used to be you would think people in their 50s, 60s, 70s, but now you're seeing people who are being diagnosed as diabetics in their 20s and 30s, and also dealing a lot with blindness or loss of limbs.
In teens, there's an epidemic of it in teens.
Yes.
Type 2 diabetes. That's where the biggest explosion is. So there's a whole new focus that has to be to place on. I mean, you got to go where the disease is. I mean, it's if teens are affected, we got to start talking to kids in junior high school and elementary school about what's that. One thing that we didn't really touch on, and that is the symptoms. What are the symptoms? What are the symptoms?
That's
and
right.
and we always talk about the 3 Ps: increase urination, increase eating, and increase thirst. And so extreme hunger can be one. People just get, I'm just starving. I just ate, but I'm starving again. Frequent genital infections. Someone is always getting vaginal infections or getting penile infections or infections in the genital area. They don't understand why. That can be related to diabetes. Unexplained weight loss. I'll never forget was a very prominent doctor here in the Bay Area who came to see me a few years ago and said, Doc, I'm losing weight. He said, I like the weight I'm losing. I'm getting ready to go to my class reunion, so I like that I'm getting thin, but I'm not sure why. And the first thing I did was a urine dipstick on for sugar, and it was positive. I said, hey, you've developed diabetes. He said, well, can we just wait until I get back from my trip? I said, no, we can't wait. We got to get you started on something. So unexplained weight loss is a sign. Sometimes people produce a protein in your urine. It's called a ketone, and it has a unique sweet smell to it.
Right.
And that could be a thing. Impotence in men, all of a sudden it cannot get an erection. It just won't happen. And that can be a sign of diabetes. Unexplained fatigue, increased irritability, blurred vision, and slow healing sores. All of these things can be signs. They can be signs of other things, but they can also be signs of diabetes. So that's really, really important.
Wow. Uh, and you hit on something with the teens. And I think one of the things that concerns me is, of course, and I know that there's a lot of lobbying around a lot of the fast food commercials and things because, people see that and they think, oh, I'm eating an organic burger. or, or,
Right.
organic fries, or they're cooked in canola oil or whatever. And I'm like, no, that is so wrong on so many levels, but there's so many people who buy into it. And I have to say, for those parents out there and all your kids want to eat is mac and cheese or french fries, I'm here to tell you, you are setting them up. I was at an event on this over the weekend, and one of the things is the kids were saying, I like eating hot stuff. And I'm like, and we're talking a 5-year-old, and I'm
Mm.
thinking, you don't let your child eat hot peppers like that, or because of what's happening. But it's all these things that we just kind of, the pendulum needs to swing back to the days of when you and I were coming up. And, for us, wholesome eating was, greens and string beans and cabbage and, things of that nature. And it's just, I'm amazed at the number of people who say they don't even eat that. They don't eat beans. They don't eat. When you talk about protein, to them, protein is a double giant burger
Yeah, piece of
with
fried chicken. Piece of fried
right,
chicken.
right.
I did a talk one day up in Sacramento, and I said we are literally eating ourselves to death
Yes, yes,
every day. We're eating ourselves to death by eating, these meals. I had I'm a pastor of a church, Gloria, and so the typical church meal is fried chicken and yada 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 yada. So I challenged my church that for 1 year we're not having no fried chicken in this church.
mm,
And at first they kind of it was hemming and hawing, but they went through it and did it. And I'm not sure how many people lost weight, but the important thing was they could do it, that they could
right,
get through it. And so now we're doing a fast, and some people are hemming and hawing, but they'll see after the week or so that they can do it, that they can actually fast and survive and will make their bodies more efficient and make them feel better. So yeah, I think that the patterns of our eating are really, really poor. And again, I just make that statement: we're eating ourselves to death.
yeah, yeah. And I don't know about other people, but I just tell you, something's got to change. And people should be paying attention now, that old saying, you're never supposed to bury your child. And I'm not just talking about due to violence. I'm speaking of people who are dying because of health issues,
Yeah, degenerative
you know,
diseases.
kidney disease. I have never heard of so many young people being, um, you know, getting, their kidney transplant patients,
Right,
they're
right.
getting dialysis, and
Right.
that's amazing to me. It's
That's
just it's like it's unheard of. So guys, that's why we're talking about diabetes today. things that you need to know, you need to be aware of. And then the thing is, just because your friend is doing it, don't make you do it.
That's
That
right. That's right. That's right.
that's the other thing, so your friend may be doing some crazy stuff, and oh my gosh, it's just amazing. But we need to stop that. So the next question that I want to pose to you, Dr. Orr, is this: Is diabetes hereditary?
I don't think a specific gene has been identified, but there's no question that it runs in families. Just no questions about it.
Okay.
In my family, I think I might be the only one without it. Father had it, mother had it. I think all four of my sisters have it. And it's funny. I always attributed Mrs. Ray to the fact that I said I was such a prolific athlete. I was always running and jumping and doing all that stuff. And somehow I kept, at least when I was young, I kept my body as a fine-tuned machine. I certainly don't do it now, though I'm starting to swim a lot more. But there's no question that it runs. It's what we call familial. There's no question that it runs in families. But it can be in one generation, everybody can have it. Next generation, nobody. Next generation, a couple of people. It's a hit and miss. I don't think there's been a specific gene located, but there's no question that diabetes runs in families.
Yeah. Oh, okay. All right. So, Dr. Orr, we're going to take another quick break. And when we come back, we're going to talk a little bit more about risk factors for prediabetes, and also talk about lifestyle changes. I mean, we'll break that down, what we mean, for those of you that wonder what's a lifestyle change. But you're on watching You Didn't Get the Memo show with my awesome guest, Dr. Harold Orr. We are going to be right back after this quick break. So guys, don't go anywhere.
Maybe you can make retirement happen. After all, you made home ownership happen. Homeschooling yourself on loans, beefing up your credit score.
So I'm pre-approved.
You were like, yes! Sorry. Color coding listings, ticking boxes, and flushing every toilet in a 20-mile radius. Home sweet home. You aced house hunting. Now get the tips you need to get on track at aceyourretirement.org.
Have you ever seen somebody treated unfairly because of the color of their skin?
Do you guys know what it means to have white privilege?
What is racism, and what do you think about it?
There's so many rewards in life. You coming into our home was one of the greatest rewards we could have ever had.
It took 20 years, and I got my third child, who was 17 at the time.
It's so cool to watch the adult that you've become, and you really have done as much for us as you think we've done for you.
All right, welcome back, you guys. Thank you so much for hanging in here with us. We are talking with Reverend Dr. Harold Orr, and we're talking about diabetes today, something that has become the forefront for me in my life. And I know that there are others who are out there. They have questions and concerns and comments. And so, Dr. Orr, before we went to break, I just asked you if we could kind of circle back around to risk factors for being a pre-diabetic. Can we circle back around to that?
Sure.
And then we'll move into some steps that people may be able to take.
I mean, risk factors are obesity, number one. The more fat you have, the more your body is resistant to the insulin and what it does. It means your pancreas has to work harder to try to bring the blood sugar down, because you've got all this fat that makes the body insulin resistant. So excessive weight gain is a major problem. Lack of exercise, not exercising enough. Again, I said, I'm not talking about running a marathon. I'm talking about, 10 hours, 10 minutes, 3 times a day, or 30 minutes daily, or sometimes some people say 30 minutes is three times a week is enough. Just get into some consistent exercise. You don't have to, again, you're not running on a marathon. Just get out and start walking, moving your joints around, letting those cells, those muscles burn the blood sugar that's in your body. And then thirdly, you gotta watch what you eat. I'm telling you, we're eating ourselves to death. We must eat a healthier meal. I was last night, when you said about the veggie the burger, and my wife and I had one last night. For the first time, I recognized how much salt was in this thing. I told her last night, I said, I can't eat this stuff anymore.
Right.
It's just heavily loaded with sodium. You can just taste it. And so I said, you think it was a vegetarian burger, it's going to be good for me. No, it was loaded with sodium, it's not going to be good for you. So losing that weight, eating right, eating the right kinds of food, and exercising. And remember, you're at risk. Black people have a higher incidence. If it is in your family, you got a higher incidence. If you're walking around exercising and you're overweight, you got a higher incidence. So all of these risk factors you look at from a day-to-day of what's happening in your life, and you have to try to mitigate and try to work against them. If you're not exercising, I'm not talking about you got to get out and go out and buy sweatsuits and join a gym.
Right.
Walk around the house, walk around the block, and begin to watch what you're eating. I'm convinced we change what we're eating, we can change the projection and the profile of our lives just by eating better, and you can overcome the propensities that are laid upon you based on your family genetics. So those are the important life changes that I think you have to make to make it less likely for you to get diabetes, or if you get it, then you're able to hopefully able to control it.
Right. And to those of you who are out there that are spending $20 a day at Starbucks because they think that they're getting I want soy milk, but you got the caramel, you got all the sugar, you got the cream on it, and all this stuff. And I'm looking at that and I'm thinking, whoa, that is way too much. For those of you who always say, I always got to have a Pepsi or a Coke with my dinner, with my meal. And some people wake up and that's the first thing they reach for instead of some water. You're reaching for a soda. I mean, you got to ask yourself what is going on, and then you want to know why you're irritable when you don't get those things. So this is all of these things, y'all. We're just, the reason why I do this show is because we want you to be informed. See, sometimes you can have some excuses, but a lot of times there is no excuse when it comes to these particular things. And that you need to be drinking water. And when I hear people say, I hate water, well, I'm going to tell you, if you hate water, just watch what not drinking it is going to do for your body. And it's not a good thing. And so this is, some major concerns around what we're doing and how we're doing it. And I'm just telling y'all, me being a Southern woman, I love to cook, and I mean, it's like that's just the thing I do. We eat 99% of our meals here. We don't eat out. That's just the thing. Why is for me, it's less expensive. And then, I just know what I'm putting into my food. When you're going out in these fast food restaurants or even just restaurants, you don't know what all you're getting. And Dr. Orr talked about it. That's interesting. You talk about sodium. I have a friend right now, and one of the concerns was her doctor was saying, what is going on with your blood pressure? And she looked at something that she was doing, and there was, oh my gosh, I've forgotten how many thousands of milligrams of sodium that was in what you're taking and consuming. And then you're doing this 4 or 5, I think it was 6 times a day. Look at what's happening. So this is why we do this. This is why we talk about these things. But on that note, in terms of lifestyle and managing your diabetes, there's one other thing, Dr. Orr, that we need to talk about. For people who are diabetic or maybe pre-diabetic, You know what's really interesting? I noticed there are a lot of people that never look at and check their feet. They don't check their toes.
Mm.
And so, one of the first things is you talked about if you have a sore or something that hasn't healed and you stump your toe and it's still sore and now it's blue and then it's black and then it's pussy and now it's running, you know. I mean, what do you say to people in terms of things that they need to be checking out? Just like you want to check your breasts to make sure you don't have any lumps. What about what people need to be checking when they have diabetes or they're actually borderline diabetic?
I think that your point is a good one. Checking the feet and checking. I wouldn't expect a patient necessarily to know how to check the pulses in the feet, but the color.
Right. Mm-hmm.
Looking at the color of the feet, or the swelling of the feet, or certainly any pinpoint little wound that begins to grow. All of those things imply that the blood supply to that foot or that lower extremity is impaired, and so it is as a physician, I can remember always wanting to check the feet, always wanting to check the eyes, because the eyes are a vision to what's happening into the kidneys. Whatever kind of vascular changes you see as a doctor, you see in the eye, you can count that's going on in the kidneys. So those things are, and so you want to look at your feet and have your eyes checked, periodically, because those are good measures to induce preventive future breakdown in certain systems. So that's an excellent point that you make. That checking the feet and checking the color and checking, being careful of wounds and how fast or how slowly heal are indicative of things that could be going on in your body that may be related to diabetes or poor blood flow or other things.
Yeah, yeah. So when we talk about a diabetic, um, is there ever an opportunity? Now, you did say that when they're on meds, but what is it a possibility that someone that's taking insulin can go from insulin to just a diabetic medication?
Oh
Or,
yeah, oh
you
yeah.
know,
You can. That's why I'm saying it's such a patient proactive disease. I've seen hordes of patients who are on pills come off of pills because they lost weight. I've seen hordes of patients who were, or especially the type twos, who went from pills to insulin, lose weight, start exercising, weight comes down, diabetes comes, sugar comes under better control, come off all medications.
oh,
So now, if you're born with an absolute deficiency of insulin, it's hard to never to walk away from it.
mhm.
But those type twos who have obesity, who correct it, who are not exercising, who correct it, who are not eating right, who correct it, it certainly is a strong possibility that they could come off of the insulin, come off of the pills if they change their lifestyle.
Right. Oh, wow. Okay. So you guys heard that. I appreciate whoever's on LinkedIn for your comments. Thank you so much. And I appreciate you guys watching. So thank you so much for that. So, and Dr. Orr, I love it. I love it. So lose some weight and exercise and, get back down to what's considered a normal weight. Although I would say, just a side note, seems like the weight charts have changed somewhat over the years, right? It used to be your certain height and you only had to fit within this niche. And I always used to say, for me as a Black woman, it just, I don't see myself being 5'9" and being 135 pounds. That was never the way I was, even growing up. So,
And they've modified it a bit.
okay.
But the important thing uh, is that, and we know when we're overweight. Nobody has to tell you that.
Right.
And the important thing when you recognize that you have that issue, that problem, is to address it, do something about it. That's the important thing.
That's the key. That is definitely the key. Okay. So when we talk about these long-term complications, guys, one last time around this, the thing is, how can they be avoided? And you've heard Dr. Orr say weight loss, correcting your diet. And I heard you say more than once in the same sentence, exercise, exercise, exercise. So, but what I can appreciate about what you're saying, Dr. Orr, a lot of times, and I can only speak for me, you go to the doctor and that whole thing is you need to exercise at least 30 minutes a day. And sometimes even with me knowing that, I'm thinking, wow, sometimes in the course of a day, trying to just scrape out 30 minutes straight. But I love the way that you couched it is if you do 10 minutes, which that's manageable, 10 minutes, I can get up and do something for 10 minutes, come back, then take another break for another 10 minutes. The bottom line is that you're getting exercise. You're
Right.
getting some movements in.
Right.
I
Right.
think that's important. So now I'm switching gears on you, Dr. Orr. Hypertension or high cholesterol, how does it really affect a diabetic patient? You talked about stroke.
It's like you're throwing more fuel to the fire of destruction. If diabetes by itself is going to cause problems, then you put in high blood pressure, that's going to add a problem. Then you're going to put in high cholesterol, that's going to add a problem. So you get all these things that are combining to do you no good. And so that's why you got to control them. And it's so important for a diabetic to control their blood pressure. So important for a diabetic to make sure their cholesterol is in a normal range. Because if it isn't, those things combine together to cause you nothing but problems. Nothing but problems.
Right. All right. So with that, let's just say that because I introduced you, and one of the things is talking about hospice care. Now, we know that when people or family members hear the word hospice, right, they automatically, oh my God, this is this is the last leg. We're going down the path. But talk about hospice and maybe how some patients have had such hands-on care that they end up coming out of hospice. They actually end up doing better. Some patients. Is
They
that correct?
can. Yeah. In medicine in this country, there are three different levels. There's
Okay.
curative medicine. That's where you're always looking to correct something, to treat something, to make it go away, make it get better, etc. Then there's palliative care. That's where you're providing comfort for a patient for long-term sequences, and that could be a palliative team can work with a curative doctor for years, and the palliative team is concerned with pain control, concerned with psychological issues, and various things like that. Then at the end, in your last 6 months of life, there's something called hospice care. Hospice care is no longer concerned about curative. It has been determined that whatever this disease that you have, that it's going to end your life. Problem is, especially with Black folks, we never really get to the point of being able to use hospice care. And everybody with Medicare and people with most private insurances have a hospice benefit. And I just too often see a patient who's been struggling, who's been going through all kinds of issues, with a terminal disease, and being treated by some of the HMOs in the area, and then they refer them to us in the last days or weeks of their lives, when they should have been referred in a much earlier course, so that we could be focused on patient comfort. And you're right. I've innumerable patients who come on our service who are near dying or getting death, who just get better. They get better because they're getting intensive care. You get a nurse coming to see you 1, 2, 3, 5 times a week. You got a home health aide who's maybe coming in and seeing you every day. You got a doctor who's coming to see you, once the 3 or 4 times a week. And this intensive care, you find things that you normally would miss with a patient coming in and see you once or twice a month, and you correct these things early on, and people get better. People get better and come off hospice every day. I'm getting ready to discharge somebody today. I saw today that they've just simply gotten better. So it's a service that all of those of you with Medicare, it is free for you. It costs you nothing, but we don't use it. I was just thinking about when I was in private practice. I don't think I ever referred anybody to hospitals because I didn't know about it.
Wow.
And so, I think it's imperative that the clinicians being better informed and those who work in acute care facilities be better informed, that we use these services that are available, and then people start asking for them. Look, my mom is at the end stage. Can she get hospice? And they're, with that window looks like 6 months or less, you can get it. Or what about palliative care? Maybe he or she is not getting ready to die, and but they're having a lot of discomfort. Can you call in palliative care to help with the symptomatology?
Mm-hmm.
So, and I love the combination in my life of being a pastor and the Christian walk with the hospice care and dealing with patients who are approaching the end of their life and helping them to take that step. I think God blessed me to do that. But hospice plays such a great role. But it hurts me, Mrs. Ray, when I go to ICUs and everybody up there on the machine is black, with suffering, and they ain't coming off those machines, and they don't have to die that way. They don't have their last days. Don't have to be away from their family. They could be in a much more compassionate situation if the clinical teams would address it in a different manner.
Mm-hmm. Yeah, I think that this is where one of the things I've been having a big discussion with a couple of women in a women group is about having healthcare advocates who understand this and who can, say, look, go in and talk to the physician, because I'm just going to tell you, my opinion, no disrespect to anybody who's watching this who says I'm a caregiver, but you say you're a caregiver, and usually it's people who have children and they're getting some kind of stipend, but are you really a caregiver? Because the person you're supposed to be giving care to isn't getting any better. Number one.
That's
Number
right.
two, caregiving isn't just about you driving into a doctor's appointment, but it's really about keeping a diary, a dialogue of symptoms, what's happening, what's going on. When they take this particular medication, they get extremely dizzy. I mean, it's all these things. And so this is why healthcare advocacy is a whole nother vein that I think that people should look at. And I know it's one that I'm certainly looking at, because I'm just so passionate about what's happening to people. And as you said, even if it's palliative care, people who are in such pain, and what do the doctors prescribe? That's why we have an opioid crisis right now, is you just give them a pill and let them be on their way, rather than to having someone who's taken the time and knows this person. And like you said, wait a minute, we gotta stop, we gotta change the trajectory of what we're seeing with these patients. And that makes me very sad to know that 99% of patients who are in ICUs are Black patients on vents, and they're not going to get any better. And guess what? And all of that we know probably could have been avoided. So that really makes me very, very sad. It makes me very sad. But you said it, you're in a good place. I could see how ministry and hospice and how that all melds together. And I'd be interested in hearing a little bit about how that story came about for you, because you've been a practicing physician for years, and now you're a pastor. How long have you been a pastor?
I got ordained in 2008, and but I've been pastoring at Great El Bethel Missionary Baptist Church in Barnchester Village, which is right around the corner from where I grew up. Church that I never used to go to. Right, matter of fact, I didn't go to any churches. Period.
Mm-hmm.
But I walked by this church every day, going to catch the school bus, and were walking when I was coming back home. That one day, so a good friend of mine, Alvin Johnson, called me and said, hey, they're looking for somebody to preach on a particular Sunday. And so I said, yeah, I'd be willing to come preach. And Gloria, when I walked in that pulpit, I knew at that moment everything in my life that God had me do was to prepare me to be the pastor of this church. Even though they had already, the selection committee had already kind of made the selection and closed it, I told them, you better open up your select because I know I'm supposed to be here. And so it's been a wonderful journey, but one journey
that calling,
and hopefully for them as well.
Yeah. Oh my gosh. I'm certain that it is. So, Dr. Orr, don't go anywhere. We're going to take, when I say quick break, a really, really quick break. But when we come back, I want give you time to think about what is it that you want people watching the show today to take away from our discussion.
Okay.
So don't go anywhere, you guys. We'll be right back.
Thank you for watching the You Didn't Get the Memo show with your inspirational host, Gloria Bailey Ray. It's your contributions that make this happen. To become a sponsor, send an email to youdidn'tgetthememo@gmail. That's the letter U, didn't get the memo. If you're not in a space to be a sponsor, but you like what you hear, we simply ask that you support what you like by making a contribution to the show. There are 3 ways to make an online donation. Visit paypal.me/Gloria Bailey Ray or Cash App or Venmo, Gloria Bailey Ray. Give what you can. Your support is appreciated.
All right, guys, if you've been tuned in, appreciate your comments. I have been talking with Reverend Dr. Harold Orr, and I'm so grateful to have had him on the show today and talk about diabetes. And the thing about Dr. Orr, he just keeps it real. He's just talking as he would, and I can attest to the way he's talking is how he talks to his patients. He cares, and he keeps it that real with them. So we're talking about diabetes, and before we took this short break, I said to Dr. Orr, what is it that you want people who are watching the show today to take away, Dr. Orr?
I want people to realize that though you have this disorder, it is no reason to give up on life. There's so many things that you can do to improve your overall condition. We've talked about them earlier. 1, learn to eat better and stick to that with that knowledge. When you get that knowledge of what to eat right, stick to it, because I firmly believe that we are eating ourselves to death. But if we slight changes in our meal patterns and the content of our meal will go a long way to improvement. Begin to exercise. Begin moderately exercise. I'm not talking about running 10 miles and all that stuff. Just a moderate, daily, consistent exercise will help your body to your body muscular, your body blood flow, your body use of sugars to burn them more effectively. All of those things will help you. And then be aware of what's happening in your body, checking your body, looking at your feet, looking at your nails, making sure that if you see something unusual, that you draw it to attention. And when you go to the doctor, don't be overwhelmed or flustered by this high-powered doctor in a white coat and tie. Write your questions down and get your answers. If you get a doctor who doesn't want to answer your questions, find another doctor. So eating appropriately, exercise, and using the healthcare system to your benefit. Using it to your benefit. I think Mrs. Ray is right that we need to have some healthcare navigators. Healthcare navigators will help people wind through all the myriad of doors that open and close in the healthcare system. That if you know how to open those doors and close them, they can work them to your benefit. So eating right, exercising, and using the healthcare system to your benefit. That's what I want you to go away with. Do not give up hope. What you do is use the God gift intelligence that you have to your benefit by eating right, by exercising, and optimizing the healthcare system to benefit you.
Yeah. Dr. Orr, don't you go anywhere. I'm going to be right back. I want to say to all of you, my viewers, thank you so much for being here with me today. It is my hope that you have found the information shared here today to be educational, to be informational, and inspirational. I want to remind all of you guys to be sure and follow me on all my social media platforms and mark your calendars for every Tuesday at 5 p.m. Pacific Standard Time for always a great show on YouTube. Didn't Get the Memo show. I invite you to, in fact, actually add You Didn't Get the Memo show to your weekly calendar so you don't miss an episode. I appreciate all of you and I thank you all for your support. It's been a blast. And as I always say, if you didn't take anything away from today's show, then it's you who didn't get the memo. I'll leave you with this. Fear and faith can't live together. So until this time next week, have a wonderful week. Give thanks for all your blessings. Stay safe and always remember to walk by faith. Pay it forward. I'm your host, Gloria Bailey Ray. Be well. See you next week.